Welcome to the SIBO Doctor podcast, hosted by Dr. Nirala Jacoby. Medical experts join us to discuss functional digestive disorders, clinical practice and research as it relates to SIBO and associated conditions. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. Head over to thesibodoctor.com and sign up to the SIBO Mastery Program and take your SIBO knowledge to expert level. If you're a patient, you can sign up to the SIBO Success Plan and beat SIBO for good. Please note, this podcast series is not intended to diagnose or treat medical conditions. Ask your doctor before initiating any new treatments. And now, over to Dr. Jacoby and the latest episode of the SIBO Doctor podcast.
Welcome back to another episode of the SIBO Doctor podcast. I took a little bit of a break over the last few months, and it's great to be back on the air again. We've recorded episodes for the SIBO Doctor podcast for the last 4 years, so it felt a bit weird to be off the air, but needed it just to kind of rejuvenate and get some of the creative juices flowing. And I want to thank all of you who have written in and suggested some fantastic podcast topics. And thanks to you, we'll have some great topics coming up. It's not too late to send us your suggestion. You can email us at info@thesibodoctor.com if you have a great guest that would be wonderful to have on the air to discuss SIBO and other digestive disorders. Today's episode is about hydrogen sulfide. We had a lot of requests for this. Hydrogen sulfide, SIBO, and LIBO, LIBO standing for large intestinal bacterial overgrowth. My guest is Dr. Joshua Goldenberg, who is a researcher, teacher, naturopathic doctor, and founder of the Doctor Journal Club. He's an active researcher with numerous prestigious publications, and his research focuses on SIBO, irritable bowel syndrome, evidence-informed practice, and research methodology. He is a research investigator at the Helfgott Research Institute and visiting research scholar at the University of Technology, Sydney. He lectures widely and currently teaches postgraduate students at Helfgott in advanced evidence synthesis methods. Welcome to the podcast, Dr. Goldenberg. Really nice to have you on the show.
Thank you so much. It's a real pleasure to be here, Dr. Jacoby. I've been excited about this podcast for a while. I'm a fan. Actually, I was a bit of a podcastaholic for a while. Then I found Audible. And so the only podcast I still do, this is not just me kissing up, is truly the SIBO Doctor podcast. Because I feel like I have to for my profession, just kind of stay up to date, hear what the latest stuff is, etc.
Well, thanks so much. Really, the topic today and the reason I thought you'd be a fantastic guest on the podcast is hydrogen sulfide. And we get so many questions about hydrogen sulfide, and there's a general confusion around this whole topic. And I don't think it's just SIBO patients; it's gut patients in general. Even researchers are sort of confused. So I thought we'd take a moment and begin the podcast with really defining what we're talking about. And you are an expert in IBS and SIBO, and we will get to your study that you're conducting as we move along, because it's a really important study for practitioners. So I'm super excited about that. So let's get started with talking about really defining hydrogen sulfide SIBO. What are we talking about?
Yeah, so I know we were supposed to talk about the study at the end, but I think it's relevant at the beginning. So who the heck knows? I think that's the big question. Like, what is the definition here? And what you'll see out in the community, what doctors are doing is pretty much falling into three buckets of definitions, right? So, and how they're making that diagnosis, how they're making that definition. And so one is basically you're actually measuring hydrogen sulfide, right? So you've got SIBO symptoms, you have a patient come in, you get a test that can actually measure hydrogen sulfide, and you're looking at a threshold. And we should actually talk about thresholds because that's been changing and based on some new research on that. The other is, been used for years, which is the flatline hydrogen in the third hour, right? So you do a lactulose test for 3 hours, If you see a flat line, and we could talk about why we think that is, the idea was, okay, that might be hydrogen sulfide. These patients have hydrogen sulfide SIBO. And then the third is empiric. There's been a bucket of symptoms that clinicians suspect are related to hydrogen sulfide. And if people meet that criteria and it still feels SIBO-y, then, we kind of put people in that bucket. And so that's how doctors have been making those diagnoses and how they've been using those definitions. And I think these are different ways of defining or making a diagnosis for this idea that you might have an overgrowth of bugs in your gut that are overproducing hydrogen sulfide, and that's what's causing a problem, right? That's the idea behind it anyway.
I think one of the reasons everybody is so sort of confused about it is that there really are no way of absolutely knowing whether or not somebody has this condition unless they, utilize this one lab in California called Gemelli Lab that does the TrioSmart test that looks for hydrogen sulfide as well. And that's a relatively new test. And, to be honest, a lot of patients that I suspected had hydrogen sulfide came back negative with this. So there still needs to be a lot of sort of hashing out what the criteria are. And so I do think it's important that we get more research in this area. But I think just to clarify for the listener, who've been tuning in for many years, we know about hydrogen SIBO, which is an overabundance of bacteria that produce hydrogen. And those are usually Klebsiella and E. coli, as it turns out. And then we have methanogens that produce methane, but we are rethinking that whole diagnosis as more intestinal methanogen overgrowth rather than classic SIBO. And then we have this third category of hydrogen sulfide SIBO, but also LIBO, which we'll get to later, which is more large intestinal hydrogen sulfide production. But that's all. Hydrogen sulfide SIBO has always been very elusive because we have no way until recently, of really measuring hydrogen sulfide because it's such as my understanding is it has such smaller reference ranges and very difficult to detect. And so there's only one lab that has created a test for this. So and also, the diagnostic criteria for hydrogen sulfide SIBO, traditionally, my understanding is we're mostly really severe diarrhea. And then we have research that actually looked at colonic production, so much further down, of hydrogen sulfide, and there it caused constipation. So can you kind of talk about what the classic symptoms are that we're actually looking for when it comes to hydrogen sulfide in general, and what should we look out for, constipation or diarrhea?
Yeah. So, okay, awesome. So there's so much to talk about there. Okay, so I think you're referring to there was a sort of a validation study out of the Cedars-Sinai, as presented at DDW this year, that essentially had three groups of people, right? You had healthy controls, you had people with diarrhea, IBS, so that was Rome 4 IBS-D, so diarrhea subtype of IBS. And as you know, Rome 4 is very strict. You have to have pain, and a lot of us see patients with SIBO that probably don't meet Rome 4 criteria, so that's one relevant piece. And the other was IBS-C by Rome 4. So in that study, they looked at hydrogen sulfide levels. And what they were able to show is that using a threshold of 5 parts per million, the people with IBS-D clustered very, very differently than people with IBS-C and healthy controls. And it's quite clear, right? So if you sort of see I'm moving my hands as if your listeners can see me, but if I can sort of describe it. So, you pretty much have a cluster of healthy patients between 1, 2, maybe 3 parts per million. There's a few scattered points, but that's essentially where most people lie. Constipation's kind of like all over the place. Again, this is IBS-C constipation. And then IBS-D really clusters up around 5 and above. So what they showed through that is that using hydrogen sulfide test, you're able to differentiate with a very statistically significant p-value, which just means, we think it's a real thing, not random chance. You're able to differentiate people with IBS-D, with diarrhea from others. And so that's the idea. And it sort of got this this reputation for being diarrhea predominant, right? Now, what's interesting is like clinically, that's not what I've been seeing. That's not what a lot of clinicians have been seeing. Like a lot of us have been seeing constipation. And it's been this issue because, you go to the website of the company and it talks about diarrhea. And if you're asking, another practitioner to order it, and then maybe they're not familiar, or they get a little bit confused, or patients get confused too. But what's interesting is, so one of the things that we're doing right now, so two things to say about that. One is, and we'll talk about it more in a second, but we're doing this hydrogen sulfide registry. And one of the things that the reason for that is to get a sense of what are all the symptoms associated with hydrogen sulfide diagnosis. So we've got a list of like 20 different symptoms, and we can go through them. But what's fascinating so far, 100 cases in, is like constipation is beating out diarrhea as far as what clinicians are putting in. And so clearly, constipation out in practice, we're seeing that a lot, and at least in these 100 cases, we're seeing them more than diarrhea when we're making these hydrogen sulfide diagnoses. So that's in a case registry that we're doing. And then if you look at the more formalized research, that validation study, if you look, and again, remember this is IBS-C, so it's a very strict definition of constipation. But in that group, the constipation patients, like their parts per million hydrogen sulfide were all over the place. Like it did not cluster tightly at all. And so, I feel like you're still seeing people with parts per million over 5 that have constipation. So it isn't so surprising. So maybe that's a long way around of saying, I don't know if it's always diarrhea predominant. I personally in clinic have seen it a lot where it's constipation. Our case registry is bearing that out. And I think if you dive into the validation data a little bit, like even though the headline is, predicts diarrhea, that isn't the full story there.
So I think it's a good time to talk about your registry and what you're hoping to accomplish, and really a call to action for all practitioners out there. We need your help to define what you're doing. How are you diagnosing? I'll let you talk about this.
Yeah, sure. So let me give you a quick fun example. So what would be like the number one, if someone said hydrogen sulfide SIBO to you, right? Like what would be the number one symptom, the classic like pathognomonic symptom that you would call out? What do you reckon it would be?
Well, like I said, if it was SIBO, I would think, from what I've learned through Dr. Pimentel, I would say diarrhea. But as you've just, confirmed to me, that's not what I'm seeing either. But I'd probably say burning bladder syndrome, or, sort of like...
Yeah, okay, nice. Yeah. So burning, yeah. What else? So that's classic.
I think that would be the number one.
Number one. Okay, cool.
Yep.
So
I'd say rotten egg gas, right? That's what we all are told.
Yeah, that's what I said for. So sort of that sort of pathognomonic, it's like, oh, it's got to be sulfur. It smells like eggs. Yeah. So we have so like that's, I think, very interesting example, because, and that's why we kind of went into the registry. And so I'll kind of come back around on the back end, but essentially like there's all these things that we've been taught about hydrogen sulfide, and a lot of them they're all anecdotal. We have very little research on it. And a lot of them, when you have, anecdotes, a lot of it's what catchy, what makes sense, what's get passed on from one clinician to another. And the thought is, if we can actually start mapping out what people are seeing, like successful case or not successful case, right? So it's not people presenting their brilliant piece of work where they cured someone in 2 seconds and it was the most genius combination. Like we want the good cases and the bad cases. We want to get a sense of what's going on. So, I had this sense in my mind of that classic symptom, the rotten egg smell and rotten egg burp or flatulence or whatever. And what it turns out, we do this registry, and it's essentially like a very, very small number of the cases, at least the first 100 or so that we see, whereas like, bloating, abdominal pain is really high, constipation, like I said, is really high, diarrhea is up there too, are way, way higher, right? And so it just kind of goes to show that what we may consider pathognomonic may actually be quite rare. So what is the registry? So essentially, what a case registry is a way to prospectively capture clinicians' cases, right? And so essentially, the thought was, we have this new machine. People have been working with hydrogen sulfide SIBO for a long time. You've been coming up with approaches. CBEC has been coming up with approaches. Most of us are following you guys, right? And you guys have been doing it for a long time. And it makes a tremendous amount of sense. And the thought is like, well, finally, we have this machine that's actually capturing, we think, parts per million of hydrogen sulfide. Essentially, you have hundreds of practitioners doing experiments every day where they're measuring gas levels, they're treating with herbs or they're treating with drugs, they're capturing symptoms, they're tracking responses. And what if we could actually gather all this data in and look for signals? Right. So this form of research is very high, what we call high risk of bias. It's sort of low quality evidence because, who's putting into the registry, and maybe you don't put in your cases that you don't want to put in all of them. Right. But maybe people aren't. So it's prone to bias. That being said, it's like a really good first step. And the thought is, if we can get a signal like, wow, like all these people are reporting constipation, right? That's interesting, right? Or everyone's using bismuth, like, that's interesting. We should look more into that, right? And so looking for these really like blaring signals to us, we could then use those in more formalized, low risk of bias studies like randomized controlled trials to actually study it. So it's a way of sort of gathering this data. And what's exciting is if we can get 400 cases. We got about 100 cases now. If we can get to 400 cases, you're going to be able to statistically look at like second order things. So, for example, and you'll need to shut me up because I just get really excited about talking about this. But
keep going. This is very good.
It's really like all this information we need to know, right? So you asked beginning, how do you define it? How do you make those diagnoses? And so we have these three buckets, right? Empiric diagnosis, flatline hydrogen, and we have the hydrogen sulfide levels. So the question is, what if what we've been considering hydrogen sulfide all this time, with these flat lines and empiric, what if they're different than what we're calling hydrogen sulfide now with high parts per million hydrogen sulfide, right? What if they're actually different phenomenon or different phenotypes of the same condition? And what if they respond differently to interventions, right? And I think you've talked about this, right? So large intestinal hydrogen sulfide producers, those may be very different bugs than the ones we think they're doing it elsewhere. Maybe they respond differently to different interventions, et cetera. And so if we get enough cases, the idea is, okay, if we take all these cases and we divide it up into people that made the diagnosis based on empiric, and then we take all the cases that made the diagnosis based on flatline versus this, and then if they used bismuth in 1, 2, 3, which one did better? Who's reporting better responses? Are all the hydrogen sulfide cases that are, parts per million based tough responders, right? Is the prognosis different? So this is like fascinating to me, right? Because we've just been kind of guessing at what hydrogen sulfide is all this time. And we're still kind of doing it. Now we just have a fancy machine that does it too. This should, I hope, help guide us. And I think clinically, like the most important thing to me, minus the validations of all this, is like it needs to be clinical outcome based, right? So like it's less important to me like how tight their is it to 5 decimal points of parts per million? Like I don't care. I want to know if it's over a threshold and I give X, can I expect the patient to get better or not? Mm-hmm. Right? That's what matters. Mm-hmm. And so the idea here is to have it really be clinic outcome driven and then use that in a randomized design.
That's great. And the link to this case registry will be in the show notes. So practitioners, please have a look there. There'll be more explanation on your website that this case registry is on. And I wanted just to kind of back up a little bit to clarify, because I know a lot of listeners' heads are swimming because not everyone's a practitioner. But I just wanted to clarify that what we're kind of talking about is that there really isn't a very good diagnostic test for these different phenomenons that we're seeing in terms of, is it actually hydrogen sulfide SIBO? We don't know. Is it hydrogen sulfide LIBO? We don't know. We're going by stool tests that are also very limited by looking at 1 or 2 bacteria that are very specific for hydrogen sulfide production, like Desulfovibrio and Bilophila. But turns out that there are a host of other bacteria that can upregulate their pathways of hydrogen sulfide production if the conditions are right? So I think we oversimplified it with that model, and I feel like we all need to sort of take a step back and think about, before we diagnose somebody with hydrogen sulfide, that we really don't fully know. The other one that you, I think what I would have said, what's the other sort of hallmark of a hydrogen sulfide patient perhaps is this sulfur sensitivity. Now, sulfur sensitivity may not be due to hydrogen sulfide overgrowth. It might be a thiol sensitivity. And the rotten egg smell gas may not actually be rotten egg. It might not be hydrogen sulfide. It may be methane thiol. So there's so many complicating factors. And I just commend you for trying to at least shed some light on this complicated issue that I think practitioners tend to simplify just because otherwise it's too overwhelming to treat, to be honest, So it's really good that we have some way of tracking some of this, because I think you're absolutely right. I think we will find there are different conditions. It's not as clear cut as just, well, let's rubber stamp this one for hydrogen sulfide SIBO. It may be that they have certain, transsulfation pathway SNPs that don't allow them to process stuff. We've talked about this before, but yeah, it just gets really complicated.
Yeah, it totally does. It's interesting. Just as a quick aside, like the sulfur sensitivity is also like one that's like less than 20% of what we're seeing, right? So, it's
really?
Yeah.
Wow.
So it's one of those fun examples where, again, it's a case registry. It's prone to bias, but it's the best we have, about 100 cases combined, where it's like a very small percentage actually are reporting sulfur sensitivities, which is interesting. So again, maybe pathognomonic, but may actually be quite rare. We'll have to see in more formal research, but that just points to the fact that it's just very hard to make these calls based on symptoms. So so I couldn't agree more. And I think the corollary to the problem that we had years ago, where it's like we had no way to formally objectively measure it and we were going based on kind of symptoms and flat lines, is now I think we run the risk of being overly scientific, right? Like we have all this precision with this new tool, but does that translate to clinical precision, right? So that's a question, I think. Just because we can see it on a graph now, do we get overly enamored with that? Do we, can it be a red herring? Do we need to pivot or bail sooner in clinical approaches? So that's a big question in my mind, and I worry as we have this very objective measure and a very solid test. The question is, okay, are we going to become overly enamored with it, which will be interesting. So I think either way, we know next to nothing about this, but based on formal research, it's all clinical anecdote at this point and some very, very basic research, which is fine. It's a start, but we really need formalized approaches based on clinical outcomes to drive this field forward. Otherwise, I'm sure you see this with patients. There are some patients I get where it's like, man, we've been at it for a while and, feels like we're going in circles and we're knocking this off and crossing this option off, but it's like, how many more options do we have to cross off here? And, and how long are we going to spend down this rabbit hole and before we pivot? And these are just really important, pragmatic questions that hopefully we can get a little bit closer to answering.
Well, you've already blown my mind in that basically none of the symptoms that we've always preached were hydrogen sulfide related were in the top 10 of the people in your registry. Yeah. So what would you say are the top 10 or the top 5 if you don't remember them all? But like, what are people saying they find highly associated with hydrogen sulfide? And a follow-up question, how are they diagnosing it?
Okay, great. So right now, I think the main, and again, it could change over time. Hopefully, after this podcast, we're going to have another 200 cases, which would be great. But so I think right now we're seeing sort of the classic SIBO stuff like bloating, discomfort, things like that. We're seeing a lot of constipation, a lot of diarrhea. So it's just constipation's winning out, but diarrhea is up there too. Abdominal pain is a big one. Which I find very interesting because, the visceral hypersensitivity connection that we think with hydrogen sulfide, which is very interesting. You're seeing some of the urinary symptoms, some of the skin manifestations, some of the nerve manifestations, but these are at least currently low counts, and then the classic sulfur, egg smelling, flatulence, and burping are much lower as well. So it'll be interesting. And then, what was the second half? Oh, how are they making the diagnosis? Right now, it's split. About a third, which is great. I think we're getting loads of different data sources. A third of people are making that diagnosis based on parts per million TrioSmart, a third empiric, and a third based on flatline hydrogen in the third hour. And
So I got a few things to say about that because, I have like if somebody with these symptoms that you just listed, which could be just practically anything IBS related, right? Bloating, hypersensitivity, that to me does not scream hydrogen sulfide at all. And if somebody, I will just say that in my experience with working also with practitioners, there's still a lot of confusion around what actually constitutes a flatline. I've seen a lot of people in chat groups and forums talk about that it's a flatline. They show the test, it's not a flatline, right? So I think there is also a bias that when somebody does a SIBO test, they will, like, we are just not willing to accept that sometimes patients are negative, on a SIBO, on a breath test. So that's also in there. Yep. So I just wanted to bring that up because that would be challenging for me if somebody made an empiric decision that this was hydrogen sulfide. Although if they then get really good results with their treatment, then of course, then that stands to reason that there was a component of that.
Well, maybe what if they used rifaximin for treatment, right? And actually it was, hydrogen SIBO all along, right? And they got better. So we don't know. And the problem is so with this registry, by definition, it's clinicians making that call. And we may disagree with how they make that call. And we have questions that try to capture that. Yeah. So we have, for example, if they make the diagnosis based on a flat line, did you use lactulose or glucose, right? So we kind of know that you should be using lactulose there, but that's an important question. Do we need to throw some of these out? Because that would obviously be a flat line, right? If it was glucose. How many hours did you do the flatline for? What was the peak level in the third hour? What was the peak part per million, right? And that's already fascinating. Like we're seeing a really tight cluster around that right now, which I think is good. So does that mean that's the right answer? No, but does that mean that at least out of 100 cases that clinicians are pretty consistently picking the same numbers? Like, that's interesting.
That's great.
That's interesting to me, right? And then also, again, if we get to the 400 levels or things like that, we'll be able to tease these apart and say, okay, well, you were making that diagnosis because we'll be able to link the symptoms too, right? So, okay, you made a hydrogen sulfide empiric diagnosis and the symptoms were constipation. Interesting, right? So maybe in some secondary analysis, we'd say, well, Neurala would not be cool with that. Like maybe we separate those out and see, Neurala kosher versus Neurala unkosher stuff. Like what do you see a different response, right? And that's the power of having like a large data set. So where you can do those secondary, tease it apart. And it could be that we're all wrong, and maybe it doesn't matter, or maybe flatline is way higher than we thought. And so the idea is to kind of gather that information. But to underline what you said, the registry is only as good as, the cases that are put in there. And so we don't want your hero cases. We want your successes and your failures. Like we want to know, what's the success rate here? We want to know what do these things look like? If you make that diagnosis, we want to know how it went and how you made that diagnosis. So yeah, we may disagree on how we made that diagnosis, but like we said, right now we have no clue how to formally diagnose it. And hopefully this gives us some sense.
That's a really good point. I mean, we just need to collect the data. And so also patients listening to this who were diagnosed with hydrogen sulfide, I encourage you to go back to your practitioner and encourage them to register your case. It's anonymous, so you will not be named, but just so that we can gather data, because we have literally just a handful of therapeutics also, that is besides bismuth, we've got the oregano oil, we got the zinc acetate. And in terms of natural therapies, it's been really refractory to treatment. So, and the vegetarian diet. I do want to say that I find that personally, I think that, and I think I mentioned that in Instagram somewhere on a study, that really showed to me that besides, when people, let me rephrase this, when people are sensitive to sulfur-containing foods like broccoli and garlic and onions, that could actually be not hydrogen sulfide related. That could be related to more of like a thiol sensitivity. And so when people are sensitive to those types of foods, that may be different from hydrogen sulfide. But then if you actually put them on a vegetarian diet where they remove all, because meat is the highest, driver of hydrogen sulfide in this study that I read. I don't know if you agree with that or not, but it seems to correlate with the patients that I see with hydrogen sulfide.
So I'm going to ask you on air, but so this is so important. So therapeutics and low sulfur diets. So for example, in the registry, quickly what became apparent was there are 3 winners in treatments. So of all the treatments we listed, and every time people kept on populating it with others, we would put that in as well. The 3 far and away winners are bismuth, oregano, and low sulfur diet, right? Not a big surprise to us. So that doesn't mean they work. It just means that clinicians are using them a lot. So we already, this study, which has only just begun, is already spawning 2 new studies. So right now we've begun design of a scoping review on low sulfur diets, which I want to talk to you about, and see if I can rope you in on air for. and the other is a safety study on bismuth. So I use bismuth a lot personally with hydrogen sulfide patients. Clinically, anecdotally, it seems to work very well for me, but it always makes me nervous. And I know the safety studies and all this, but it's I don't know, how long can I use this stuff? How high can I go? I seem to need to go pretty high for a long time. Are we sure that's cool? What if it comes back? How many rounds? And so I just wanted to know more about the safety perspective of this. So we've got a toxicologist. We're putting together a doctorate in pharmacy. We have a great research team to do a systematic review on the safety and adverse events of bismuth, different types of bismuth. So that'll be useful, I think, in the literature for if we're all using this, we need to know more about the safety of it. And then for low sulfur diets, what the heck does that mean? I know you've got a low sulfur diet, and I want to talk to you about that. And it's what does that look like? What does the literature say? So we're in the middle of a scoping review on that to get a broad sense of what's out there on a low sulfur diet. And to your point, at least the data as I've seen is on vegan diet. So a vegan diet easily has 1/3 less sulfur than a standard diet. And so what is a low sulfur diet? Is that equivalent to a vegan diet? In which case, is it just a vegan diet, or is it a vegetarian diet, or is it low sulfur means you have to go even lower than that, right? And so so I don't know. So that's the idea behind the research. We'd love to have you on board as a content expert, actually, if you're available. We'll keep your time limited, but we would love your expertise on that, because I know you and I'd love to hear it. I'd love to hear more about your thoughts on low sulfur diet. It's top 2 on interventions that we're seeing. And
look, I'm happy to help you in any way I can. And from what I know, I do think I had this really great conversation with Greg Nye, who was a podcast guest, and he talked about kale being the number 1 food that he found to be quite reactive for people with sulfur issues. I usually, I haven't seen that per se. I think that there is a category of sulfur-containing foods that are, in general, reactive for some people, which I suspect is not necessarily hydrogen sulfide, as I mentioned. There are thiol issues. So maybe more along the lines of, these people are also sensitive to other thiols like glutathione and NAC and stuff like that. So, but generally, I think what I usually do is I do put them on a vegan diet, and I tell them to reduce their sulfur foods for a month only. Right? So that's easy to do. It's not hard. And that gets usually a pretty substantial results, not constipation resolution. It doesn't typically, sometimes, not typically, but it's more bloating and reactivity and bladder pain and burning symptoms in general tend to really respond to that. I'm happy to contribute in any way I can with that. The question I had about the bismuth, because I'm curious about that, is there are lots of different, there's bismuth subsalicylates, there's bismuth subgallate, and there's bismuth subnitrate. Which one are you using?
Yeah, so the registry is capturing all of them, right? So if someone clicks bismuth, the next thing down is, okay, what type are you using, Pepto-Bismol, or using it from phase 2, like, et cetera? Are you using subnitrate, like salicylate? What are you using? And then also the milligram amount of the bismuth is captured next, and then the length of time. And that's interesting too. Like, we're seeing like a bimodal distribution. Some people going really high on bismuth and some people going relatively low on bismuth, which is curious to me. Not so much in the middle. It's either like you hit them hard or like you go gentle, it seems like. So I think people seem to be using things across the board. I use, and I'm probably going to be like crucified for this, but I use a lot of Pepto-Bismol a lot, and I know it's a terrible thing, but I'd say that for most patients, at least in my experience, in my practice, they can handle the sugar alcohols pretty well. They don't mind the taste or the color, and it's the cheapest way to get a high amount of bismuth. And I tend to dose pretty high. And then for people that are more sensitive, we'll use different formats and things like that, or different products. And then we always talk about it, et cetera. But I'd say, for most people, that seems to be a quick and easy way to get that much bismuth in. But then interestingly, clinically, people seem to be using stuff across the board. So it'll be interesting to me. There's also a thought that, and I don't understand the mechanism here, but I've heard this anecdotally, and maybe you can explain it to me. Oh, and then I have a question I want to ask you about the sulfur diet. That some forms of it may be more potent than others, right? So you may not need to dose as high if you're, using, phase 2 is what I've heard, as opposed to, just straight up salicylate versions. So I find that interesting. I don't know if that's true or not. Again, maybe that's something we could piece together. And then,
are you talking about the phase 2 biofilm bus?
Yeah.
You're talking about that product, right?
Mm-hmm,
okay.
Yep.
Okay.
Yep. So that's a biofilm designed by Dr. Anderson for biofilm disruption. I have no association with this company, but it also has bismuth in it. So the question is, and that's another thing, confounding factor.
Yeah, that's another thing, right? What are we treating? Yeah. Are you busting that open? Yeah. And then you're going in with the oregano oil,
Yeah, exactly. How is it working? Is it working? How is it working? So I have no idea, right? So that's the idea of these studies. So interesting. So like we try to tease that apart in the registry to separate if people are trying to bust up biofilms versus go straight bismuth. But I think that's a really interesting question. I'd like to know more about it. And then we don't have to answer it now, but I'm curious before we get off the air, when you do low sulfur diet, so because we're at this issue now, we're trying to decide how we define it when we do our literature review. Is there like a number, is there like a milligram amount of sulfur that people are like, okay, this is consistently what we would call low sulfur diet? Or is it like you just qualitatively tell them, go vegan, avoid cruciferous, and we'll call that low sulfur?
Yeah, that's what I do. I do the latter because it changes for different people, in terms of some people can handle way more than others. And so typically what I do is I remove most sulfur. I don't even go no sulfur because I think we need sulfur. It's not like it's a healthy thing to do long term. That's not, I often tell my patients, This is something we are going to go do this for a month, and then we're going to reintroduce foods. And typically I start with the vegetables again, before I go to the meat, and then we kind of work from there. But it's really individualized, but typically I tell people a month of low sulfur. Some people that are really very responsive to this will react to it'll be a night and day when they reintroduce the sulfur. So that to me is pretty strong evidence. And also those are the people that respond very well to the bismuth in my experience. And they can tell a huge difference when they use the bismuth. And, I have people that refuse to get off the bismuth and oregano combo, and I have to reason with them.
Yeah.
But I always tell people, look, hydrogen sulfide producers are not the enemy. It's not that these are not typically pathogens that are causing this. These are pathobionts that live there normally. They have overgrown for some reason or another. And it's usually a combination of events that takes place for that to occur. So, I really, over the last 10 years that I've been focusing exclusively on SIBO, I think I am not as absolute anymore. I know much more now, so it's a bit more individualized, and I use a lot of stool testing and microba. We have a lab here that looks at actual hydrogen sulfide production as by the microbiome. And I find that's also really helpful. I haven't found one in America that does that. But again, here we're talking about stool, which is representative of the large intestine, not the small intestine. Mm-hmm. So
right.
There's still limitations to what we can do there.
Totally. Yeah. Interesting. It's so a couple of things about that. One is I agree with you completely. I feel like the more I learn, the less I feel like I'm comfortable saying I know. And the other is so much of what we do for SIBO is so aggressive. And I all these antimicrobials and these extreme diets. And I just worry so much about upsetting the apple cart of a microbiome. You've got this ecosystem trying to find equilibrium, and you want to knock it, but not too much. You want to just knock the right pieces, but not upset the whole apple cart. And so, yeah, I struggle with that, especially with hydrogen sulfide, because some of the interventions are a lot stronger, and I feel like we have less of a sense of what we're doing. Like you brought up a really interesting point with the biofilms, right? Like, are all biofilms bad? Probably not. Like, there's a natural, development in the ecosystem to have these biofilm-like developments, and even if they are bad, a lot of them are stable, right? And so, like, you have this sort of stable environment where you're kind of hiding the really scary guys, and what happens if you break it open, right? What does that look like? What does that do? So, yeah, I don't know where I'm going with this, except to say that SIBO is it's a fascinating area. And when I say SIBO, I also mean like LIBO. I'm just, it's just a fascinating area to work. And it's exciting because we're at the cutting edge of knowledge of this. Like, we know so little about it formally, but people are suffering. There's so many people with this, and they're suffering, and they need answers. And it's not like you can be like, well, we're working on the study, I'll call you in 2 years, or, RCTs or randomized controlled trials are 10 years away. So, come back then. It's like, people need answers now. It's this, really, from a clinician perspective and a researcher perspective, it's an awesome place to be. But I totally hear the patient frustration too, because it's like, wow, you're a clinician that focuses on this and you don't know what's going on here, right? Like, so that, it's kind of a mixed bag.
I start to shift my thinking in terms of SIBO more to intestinal dysbiosis or imbalances,
Yeah.
So, and a lot of people have that. Some people have absolutely true SIBO where their migrating motor complex is just, not functioning. And that, to me, is true SIBO. And there are other states, and I mean, not to say that the other reasons are not legit and in terms of causing SIBO, but there are lots of states where it's just gray area, even though the lactulose breath test is positive, and yes, you have SIBO, but okay, it's at the 100-minute mark, and it's in the transition zone, and what if it's just an imbalance in the normal, like it's just, a state that has developed due to lots of different reasons. And so I really try to steer away from this. We've got to hunt down all the last little remaining bug that's doing this. It's just, I don't think it's doing us any favors, because then what? It's just, anyways. So yeah, look, you and I could talk for hours. I know this because I think we're very aligned with how we think about the microbiome. And I'm grateful that people like you exist that are really into research, because I'm not that much. I'm a clinician primarily, and I don't have the brain for it, to be honest. So thank you so much. Before we end, let me just ask you about where people can find you, both as a practitioner and also where they can, where you are, and where they can find out more about your work.
Sure. Thank you. Yeah. So I wear 3 major work hats. So one is a teacher. So I teach at AIHM, which is the Academy of Integrative and Holistic Health and Medicine. And so I teach fellows there. So if you're a medical doctor or a naturopath or a chiropractor going and doing a fellowship, I'll teach you how to evaluate research. So you can find me there. I am a researcher at Helfgott, which is part of NUNM, the National University of Natural Medicine. So you can find me there. And then clinically, I see patients 1 day a week, and 99% SIBO. So that's GoldenbergGICenter.com. And yeah, those are the main places I am teaching, research, and clinic. And I love that diversity. I feel like clinic makes me a better researcher. You're asking clinically relevant questions, and research makes me a better clinician, right? I think it keeps me keeps the clinician hubris in check, right? Like I love talking to people like you where you've been practicing for so long, you're such an expert in this that you're like, yeah, there's so much gray. Like it's not clear cut. Like I get really nervous when people are like, no, that's not how it's done. Like, that's not what that is. I'm like, well, okay, well, maybe. I mean, like, how do you know that, right? Okay, it's not in the your protocol, but and what's that based on, right? So I love that. I think, medicine is a practice and we're learning and evolving together. And as clinicians, one of the things that's been so beautiful about working in the SIBO space is, like people like you and Allison, I mean, you've taught us so much. And I mean, we would be nowhere without you guys, right? Like you've taught us so much. And there's this spirit of sharing and co-learning, I think, that happens in this community. And it's just awesome. It's just such an awesome community to be a part of. So I love it. And I love learning together with people and learning from other practitioners as well.
Thanks so much. That's very kind of you to say. We've been at it for some time, but I think the more I know, and that's pretty much what you're saying too, the more I know that there are so many different influences on this word SIBO, right? So that's always the challenge, to really individualize our treatment. Dr. Goldenberg, it's been an absolute pleasure to have you on the show. I can't wait for you to come back to talk about the results of this and what you found and where to go.
Yes, that'll be a fun part too.
Yes, that would be really excellent. So thank you so much for your time.
My pleasure. Thank you.
Thank you for listening to the SIBO Doctor podcast. We hope you find the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, the maker of outstanding breath testing equipment. Thanks again for listening.